Hello, everybody. Welcome to our COVID lecture today, and it is regarding the management of BCG unresponsive bladder cancer. We have a fantastic panel here today, and I'd like to take a little moment and introduce everybody. My name is Sima Porten. I'm one of the associate professors at UCSF. We also have Dr. Sumeet Bhanvadia here today from the University of Southern California, Dr. Janet Kukreja from the University of Colorado, Dr. Katie Murray from the University of Missouri, and Dr. Sarah Psutka from the University of Washington. And this is a case-based discussion, and we're going to cover all things BCG. This wouldn't be a lecture about BCG unless we also discuss a little bit about the shortage, but we're going to be focusing our attention on particularly those who have varying response to BCG in terms of treatment of their bladder cancer. These are our disclosures here. And I would like to start by using some of the terminology that we'll be talking about with you today. BCG failure terminology, BCG refractory, BCG unresponsive can be somewhat confusing. And so we sort of wanted to put those definitions before we start. So BCG relapsing disease is the recurrence of high-grade disease after achieving a disease-free state post-BCG. And this can be defined as early, intermediate, and late. And this timing is really important, particularly in those that relapse early, which is less than 12 months. This is also used as a clinical trial definition, and particularly those that are candidates for some of the recent drug approvals, as this particular BCG relapsing patient is considered BCG unresponsive. BCG refractory disease is a terminology that we've all heard often, and this really denotes patients who do not reach a disease-free state at 6 months after having adequate BCG, right? So these are patients with CIS or high-grade TA after induction plus maintenance or 2 inductions, or patients who are high-grade T1 after induction BCG. Again, when you can also add in these patients, BCG relapsing patients who recur early, and those are really considered this new kind of terminology of BCG unresponsive disease. There's also BCG intolerant patients who can't get BCG due to adverse events. Another really important point, patients don't fail BCG. BCG fails to treat a patient's cancer, and so we wanted to make sure we state that out front at the beginning of this lecture. So let's jump into our cases. So case presentation 1. In January of 2020, an 84-year-old gentleman presents to your clinic with hematuria. Like many of our other 84-year-old patients, he comes with a set of other cancers and comorbidities. And in particular, this gentleman has had metastatic prostate cancer, radiation on Lupron, and has had germline analysis with a CHEK2 mutation. So there's many other treatments in his future likely. He has AFib, is on anticoagulation, and has had no other real major operations. He does live independently, and he's the primary caregiver for his wife with dementia. So a CT urogram done to work up his gross hematuria showed multiple small enhancing nodules, but the upper tracts were completely clean and there was no lymphadenopathy. Cystoscopy showed what we see here, multifocal tumors measuring somewhere between 1 to 2 centimeters. A TURBT was done. Pathology showed high-grade TA and T1. Muscle was present. There was no CIS and no lymphovascular invasion. A repeat TUR was done again because he had high-grade T1 disease, and this is per our EUA guidelines, and there was no residual disease, which is great for him. He received BCG induction. This was complicated by severe urgency and urgent continence, but he was able to make it through. He had cystoscopic surveillance that was negative for malignancy, negative cytology, and so he proceeded on with maintenance BCG. He did well with this for a bit of time. And in January of 2020, your surveillance cystoscopy shows erythematous patches and a cytology that was positive for high-grade urothelial carcinoma. You again repeat the workup with a CT urogram showing bladder wall thickening, unremarkable upper tracts, and again, no lymphadenopathy. And when you do a TURBT, you find carcinoma in situ in the bladder. However, the prostatic urethral biopsy is negative. So in this case, you try some more BCG, a repeat induction. However, this does not work, and it ends up that this patient has carcinoma in situ, as shown by this blue light positive patch here, which was biopsied in the operating room. So I wanted to pause here a little bit and again go back to some of our definitions of BCG unresponsive disease and BCG relapse and refractory disease, because I think this case brings upon some areas of confusion that can happen when BCG has failed a patient, right? It should be really clear. When there's a recurrence after having BCG, this is considered BCG failure. But I think that there is a lot of implications in terms of prognosis. Not all these patients have prognosis, bad prognosis. And that, you know, when this gentleman first had his recurrence with CIS after having induction and maintenance, it was just at that time period over 12 months. And so he really would have not been truly BCG unresponsive, and it would have fallen in these relapse categories of intermediate and late relapse. And so in this case, you can possibly derive some benefit from reinduction with BCG. And this is sort of where I struggle. I think, you know, if you meet a clinical trial definition of BCG unresponsive disease, these treatment options listed here are really what you can talk to patients about in terms of next steps. But for these intermediate and late relapses, I would have done what I think Sarah did, because this is her case, and I would have pushed with a little more BCG. And Sarah, did you want to talk a little bit more about that?
Yeah, so obviously this is a tough case. It's an older individual, a lot of comorbidities. The metastatic prostate cancer story has been, of course, evolving synchronously with the bladder cancer story. So he has progressed during the course of my care for him from castration sensitive to castration resistant. And so we're constantly sort of negotiating these competing comorbidities. But this is truly relapse. He had a period where he did respond. And then he came back with CIS, and it happened within about a year. So he's right, like Sima said, on that border between sort of late early, and intermediate relapse. And because we were definitely trying to preserve his bladder, he's an 84-year-old who has a radiated pelvis and is dealing with this other potentially life-threatening malignancy. You know, cystectomy is something we are using as an absolute last resort. It's also an anticoagulation, and he also can't really afford to not be at home taking care of his wife. So there's a social situation as well. If he had recurred with T1, we know that the guidelines say if you relapse after appropriate or adequate BCG with high-grade T1, radical cystectomy is the preferred answer. Those are not patients who we should be trying to salvage their bladder with for their topical therapies, unless it's within the context of a clinical trial. And there's not a lot of good options in that situation. But the guidelines do suggest at this point that if we have a relapse, especially this intermediate window, with not T1 disease, so either CIS or the high-grade TA, we have a couple of other options that allow us to consider bladder preservation. So intravesical gemcitabine and docetaxel is a doublet of chemotherapy, and we're going to talk a little bit more about that, is one option that is approved in the guidelines. There's no level 1 evidence for this, but we'll review some of the retrospective data. Intravesical optimized mitomycin C is actually something that definitely can be utilized, has pretty good outcomes. There are concerns, I think, we've moved as a community away from using intravesical mitomycin C, largely because of the tolerance issues. And there's, of course, something that a lot of people talk about, which is this risk of sort of developing really severe refractory bladder symptoms, and essentially a devitalized and dysfunctional bladder that can substantially impact quality of life and function. And so that's something that's sort of a feared consequence of mitomycin C that has sort of, that plus the expense has sort of moved our community away from it as we've all sort of embraced gemcitabine as a primary intravesical chemo. And then intravesical valrubicin, there is actually level 1 data for that. And that was what was in the guidelines uniquely for a long period of time. Of course, now we have a couple of other great topical options. And then we're going to spend some time later in one of our cases today talking about systemic pembrolizumab, which obviously is a newer option. So with this gentleman, I carefully reviewed intravesical gemcitabine, docetaxel, valrubicin, and systemic pembrolizumab. And we'll talk a little bit more about sort of how we kind of went through that discussion. In terms of the facts, BCG unresponsive disease, unfortunately, is really common. So with induction BCG, when you look in the bladder at 3 months, 70% of people are going to have a good response and not have cancer. But the 5-year recurrence-free survival is 25%. That means 75% of patients who get BCG, their cancer is going to come back. And that's a statistic that I think is really important to hammer home for patients early. When patients have a diagnosis of high-risk EUA high-risk non-muscle invasive bladder cancer, I have a conversation with patients where I say, listen, this is going to be something that is going to be essentially a chronic illness. We are going to be dealing with this. You and I are going to be friends for a really long time. And that's something that I think a lot of patients think, oh, you just give me the medication, I'm good, I can go. But no, this is something that we are going to be contending with. And I tell them, I said, we're going to go through iterations of treatment, and we're going to have periods where we're winning, and we're going to have periods where we take a step back. And I think setting those expectations early is really helpful in terms of helping patients understand what this is going to look like, how it's going to impact their life. You know, we can get into all kinds of discussions around things like financial toxicity and sort of the quality of life implications, but this is something you have to set this expectation early. The maintenance regimen that we talk about here, this is the SWOG protocol it's basically based on the guidelines. This is what we all use. That's a 3-weekly dose. I call it a booster dose in my clinic that the patients get at, if everything's going well and they don't have any evidence of recurrence, at 3 months, 6 months, and then every 6 months for a total of 3 years following their induction course. And then Sima had made a really important point about sort of the clinical trial definition of what is adequate BCG. If they just have a recurrence after that first induction course, technically that's not a failure at that point. The clinical trial definition of optimal or adequate BCG is they have to get more than, equal to, or greater than or equal to 5 of the intended 6 doses of their induction course, plus at least 2 maintenance doses. So that's that 5 + 2 definition that she brought up in one of the earlier slides. And then, or you can give them, or it can be 2 sequential inductions. And it's important to know that half of patients who get a second induction course are still going to have their disease come back. So in terms of setting expectations, these statistics are kind of helpful to have in the back of your mind and to bring up to patients and to normalize the fact that these recurrences are common. I think it's, and then it's also helpful to understand what the clinical trial definitions are, because that has implications for how we move forward in treating patients.
Yeah, and I just wanted to make one additional point about the induction and also needing maintenance. For high-grade T1 disease, if that's what you start with, and you give induction BCG, and on your next cysto, you see high-grade T1 again, that's considered also BCG unresponsive disease. And many would argue that that is the highest of the highest risk of patients. And so really should be moving towards cystectomy, and we'll address that. And we'll be kind of presenting these definitions of BCG unresponsive, relapse, refractory, a mix of the two throughout the presentation, just to kind of discuss some of the nuances, and also the really formal clinical trial definitions that are being used. And so I think Dr. Psutka referred to these guidelines. You know, refer to these often. It can help sort out some of the confusion with these different states of BCG responsiveness. And then I'll move on to the next slide in terms of next steps. And you had mentioned again that this is where you discuss these options with him, and that gemcitabine and docetaxel was sort of selected. And it looks like he's done well thus far, but again, we know patients are always going to be on surveillance on this, and we'll see what ends up happening. And I'm going to turn it back over to you, Sarah, regarding discussion of the data surrounding gemcitabine and docetaxel.
Great. So this, they say necessity is the mother of invention, and this data actually was born out of that true necessity. Obviously, we're going to have a little bit more information in some time about the BCG shortage and how that's impacted all of our practice. But in the setting of not having enough BCG, there was a push towards trying to figure out what else we could use intravesically to impact the outcomes with high-risk non-muscle invasive bladder cancer. So this is retrospective data from, it's a multi-institutional study. The cohort was collected over about a 9-year period. There were 276 patients at the median follow-up of just under 2 years. And the people who were entered into this cohort, the inclusion criteria was recurrent non-muscle invasive bladder cancer with a history of BCG. So BCG unrefractory, although only 40% of this cohort met that technical clinical trial definition. The regimen for this, for gemcitabine docetaxel, the doublet therapy, is they get gemcitabine, and it's 1 gram of gemcitabine in sterile water. They hold it in their bladder for 60 to 90 minutes, followed by, after drainage, docetaxel intravesically that's held then for 1 to 2 hours if they can hold it. If patients get through that initial 6-week induction course, then they go on to maintenance. And this study, the maintenance regimen that was utilized was 1 dose per month for up to 24 months. The retrospective data would suggest that 40% of patients do have some adverse side effects from this therapy, but most patients can get through it. Only 9.4% of patients had symptoms that impacted their ability to actually make it through that 6-week induction course. 9 patients couldn't get the full treatment course, and there were delays in 17 patients. And then this is the crux of it, is the oncologic outcome. So at 1 year, the recurrence-free survival is 60%, at 2 years, 46%. The high-grade recurrence-free survival at 1 year, 65%, compared to 52% at 2 years. And about 15% of these patients during follow-up went on to cystectomy. If you go to the next slide, these are just the Kaplan-Meier curves showing again. So the number to think about is the 2-year recurrence-free survival from in combination intravesical gemcitabine and docetaxel, at 46%, high grade 52%, 2 years. That's the data that you want to kind of have in the back of your mind. And then the next slide just shows the maintenance data. There's not a lot of data on this. This is a retrospective study that was recently published that just basically looks at 66 patients from one institution who were treated with gemcitabine and docetaxel. 70% were NED at 3 months. Now that harkens back to the data I already gave you for BCG, initial BCG response at 3 months, complete response 70%. So we're talking about the same amount, but these are people who've been pre-treated with BCG previously. And if they're negative, then they're eligible for maintenance. The maintenance course here again is once a month, monthly for 24 months if they can make it that far. And this is a study where they compared patients who went on to maintenance versus observation. 17 of these patients ultimately went on to maintenance, 24 went on to observation. And here's the important point, is at 1 year, the folks who were on maintenance, the recurrence-free survival was 81% compared to 42% for the patients on observation. Clinically significant, both clinically significant and statistically significant. The 2-year data is not statistically significant. There is obviously a clinical split in the curves, but obviously it's a very small number of patients because this is a relatively small cohort. So there is some data to support the utilization of maintenance. I certainly use it in my practice. I don't know the rest of the panel, your thoughts on that, but we think it's fairly important to try if patients can do it. But obviously then if this doesn't work, then we have to move along to other options, and we'll talk a bit more about that.
Of everybody on the panel, who utilizes gemcitabine and docetaxel as part of their treatment strategy for BCG unresponsive disease for patients? I mean, I know I do. And do you guys all use maintenance? Yeah, me as well, for these patients. And so I'm going to move on to the next slide in the interest of time. So for our second case, this is a 76-year-old African-American gentleman who presented with intermittent gross hematuria for many months. So similar age and presentation as our first case. He has some comorbidities. He is a smoker and is a current smoker, and again struggles with being able to get in to see physicians and driving to appointments, and has minimal family support. He had a standard exam and workup. A cystoscopy showed a 4-centimeter tumor. Imaging was clear in terms of upper tracts and lymph nodes. and he underwent a TURBT, which was a high-grade TA. Muscle present was not involved. He had Dr. Murray did a re-resection with CIS only, and this is likely just to ensure tumor clearance because it did look like his tumor size was a little bit on the large side. He was treated with induction BCG. He had maintenance. This is all per the SWOG standard protocol. However, at his first surveillance cystoscopy after his first maintenance, so this is at the 3-month follow-up, there was recurrent tumor and erythema. He was taken back to the operating room for 2 resections and was found to have high-grade T1 with CIS. Muscle was present and not involved. And again, here's the slide looking at our BCG terminology. And so this is a patient who can be defined by a few different things, but particularly he is in that BCG refractory group where he got appropriate BCG and has a clinically significant recurrence. So next steps. Dr. Murray utilized a different option in this case. And Katie, I'm going to let you take over here in terms of decision-making for pembrolizumab and also to go over some of the data in this case.
Okay, great. Thank you. So, you know, I think one thing that I will point out that Sarah said early on, right, this gentleman recurred quickly with high-grade T1. Of course, our #1 thing is to push this gentleman for a cystectomy. He's a 74-year-old gentleman. He overall, from a functional status, would have done well with cystectomy, but absolutely refused to have that done. From overall, from a social situation, taking out his bladder, also because of his reliance on coming to appointments, also would have been an ideal situation, but just can't wrap his head around that idea. And so we talked about many other options, right? And the fact of coming to the hospital once a week for any sort of installation into his bladder was close to impossible. He also has a history of some illicit drug use, and you know, it just really made these options not possible. With the CIS, we talked about systemic pembrolizumab. And due to that, kind of all of these conflicting factors and put it all together, he decided to give this a try and started, you know, Q3-week pembrolizumab in concordance with my medical oncologist who runs clinic at the same time, you know, that I do. And so I'm not giving that myself, but he's giving that. And, you know, so far to this point, the patient has been doing well, minimal to no side effects with his systemic therapy. He did, due to, you know, these social situations, miss a dose early in the course. And he's had a couple of follow-up cystoscopies with negative cytologies, as well as negative cysto in the clinic. The other thing, you know, that I would point out is, you know, making sure to monitor these upper tracts and making sure that I'm monitoring for any lymphadenopathy. So I do CT urograms, you know, fairly often on these individuals, you know, every 6 months. For a period of time in a gentleman like this. And so then I think the next slide, we have a little bit of just a quick overview data on Keynote 057 that got the FDA approval for pembrolizumab. And I think, you know, Sarah pointed out earlier, what's a number to remember when you're talking to your patients. And these are patients approved for CIS with or without papillary disease after BCG. And I think it's really important for us to realize that this is that CIS with or without papillary disease. Complete response at 3 months was 40%. In the trial to date, no progression to T2 disease. And so I think that's really that number with a median duration of complete response at about 1 year at this point in time.
And Dr. Kukreja, do you use pembrolizumab, and do you give it, or do you coordinate with the medical oncologist in terms of referrals?
Yeah, I do, and do it through our medical oncologist. It's interesting when you have a discussion with a patient that's at this point, when you talk about the response rate of pembrolizumab, you see the number 40% here. The number I give them at 2 years is 20% though. And so when we're talking about, what is the most effective, and then, the numbers that Dr. Psutka showed us, that gemdosi for CIS is like 38%, I think, at 2 years. So the options are getting slim. And so I think, pembrolizumab is great. I think it's great to use. But in a patient that has good performance status, like I really, kind of make sure that they're aware that the chances of this going away are fairly low.
Yeah, I think that brings up a good point. How about you, Sumeet? Do you use pembrolizumab in your practice, and is it with a medical oncologist in conjunction with them? Yeah.
Yeah, I think similar to everyone else, when we do prescribe it, when I do prescribe it, or do refer patients, it's through our medical oncologist, which, in an academic setting, that is not an insurmountable barrier. But I do think for the reasons we've discussed, I'm not sure how much of a sort of durable option this is for us as urologists, as a community overall, because of, not everybody's going to have that option. And in their update on this trial, there were, I think it was about 40% of patients who did ultimately end up getting a cystectomy. So again, just speaking to the same point that, it's not just about this initial response, it's the durability, and even beyond that 1 year, or that 18 months that they published initially, but just preparing patients for, like Sarah said, this is a chronic disease. And I think we're going to get to that later too. As time goes on, time in and of itself in this disease is unfortunately a risk factor as well. So just things to keep in mind.
I think that's a really good point, and that gets us into our next case. A 72-year-old robust gentleman, so not too many comorbidities at all. He had high-grade TA, no CIS, about 5 years ago, and received BCG induction. And he's gone this whole time, these 5 years, with no recurrence. So he was in that lucky 25% thus far, but we're heading to maybe things are not looking so great. He had multiple surgeries for urethral stricture disease and stress incontinence that had come from radiation for localized prostate cancer, and was getting cystoscopies fairly often for that reason. And your colleagues ended up seeing this on cystoscopy. And so there's this redder area down low and some of these papillary tumors up high, and cytology was suspicious for high-grade disease. Next steps for this gentleman, he went to the OR for blue light cystoscopy. TRBT showed high-grade TA disease. BCG induction was completed, and flexible blue light in clinic showed biopsies that were consistent with small areas of carcinoma in situ. And so, Sumeet, I think this is your case. And so I'm going to turn it over to you for discussion, but particularly I wanted to ask about your use of blue light in the situations, in the management of patients in terms of surveillance, and then also for the operating room after receiving BCG.
Sure, thanks, Sima. So speaking first to blue light cystoscopy in the operating room, well, we know that the utility is pretty significant in all patients with existing bladder cancer. You can see here, this paper is a few years old now, but basically using both white light and blue light together, you really can get extremely high sensitivity for picking up both low grade and high grade lesions. But particularly when we're talking about carcinoma in situ, this patient did have some of these red areas, although it was obviously an irradiated bladder, so that kind of was a bit confounding. But high-grade cytology, blue light certainly does much better than white light alone in picking up gas. In terms of blue light cystoscopy in the clinic, the flexible blue light cystoscopy, which is not widely available yet, we have found that it is extremely useful. Particularly during COVID, it allowed us to do a lot of very specific surveillance and a lot of biopsies because of the nature of the scope and the setup and the fact that it has a suction on it. You really can work for quite a while with good tolerance in the clinic. And so in this case, it was particularly useful. What I will say is that patients who have irradiated, who have had pelvic irradiation, I shouldn't say their bladder irradiated, but obviously you see the effects of that. I do find that blue light can often be, it can often be just as confusing with blue light, and so you do have to do those extensive biopsies. But overall, yes, very helpful.
Awesome. And then what were you considering in this gentleman as he was kind of moving through? It's almost like a, it had been 5 years since his first kind of treatment course with his disease in BCG, and now it's the same thing sort of again. And so what were some of your thoughts regarding using BCG again, how much you were going to use, when you were going to call it, and those types of issues?
Yeah, so for this guy, there was a couple of different competing things. On one hand, he's sort of our recurrence after BCG, but he's our good actor, right? It's been a long duration. He had one induction course. He really was surveilled very closely and appropriately and never had a recurrence. And so from that perspective, I think certainly, doing BCG induction and giving him all the sorts of numbers we've talked about, but feeling kind of optimistic that he may have good response with that. On the other hand, this is all going on in the setting of somebody who is increasingly working his way to being almost a bladder cripple with everything that's going on with his urethra and his other surgeries. And regardless of that, though, as we've talked about, yes, the initial response rates are good. The 5-year response rates overall are quite low at 25%. And so my standard spiel includes a discussion of cystectomy up front, particularly in this gentleman, with the sort of caveat that I was not pushing him to cystectomy now. I didn't think that was the first right step, but that these are things that we needed to think about and would keep coming up. So for him, so overall, again, 50% of patients will respond to a second course of induction as well. And particularly those with TA and carcinoma in situ. The second set of biopsies I did, although the blue light showed a large area that looked abnormal, I took many biopsies and only one came back with like early carcinoma in situ. So for him, we did feel like a second induction course was warranted and was appropriate, and so that's what we did. But then unfortunately, after that, he again had carcinoma in situ and cytology that showed high grade. So.
Yeah, and so again, these are options for BCG unresponsive disease, and we've discussed a few of these and also talked about cystectomy. And so, what did you end up considering for him?
Yeah, well, just laying out the options here. I mean, again, cystectomy is a standard of care option, or these bladder sparing salvage options. If he had been high grade T1. Really, we're talking cystectomy, unless that is something that just cannot be done. But since he had carcinoma in situ, these were things that we discussed. There's 2 FDA approved options currently. We've already talked about Pembro. There's also intravesical valrubicin, which has pretty abysmal outcomes, and so I don't think that's really used at all much anymore. I certainly don't use it. Intravesical gemcitabine, we've also talked about as well, not FDA approved, no level 1 data, but widely used for sort of the ease of logistics and the familiarity. And patients, in my experience, have tolerated it quite well. And so that is our first go-to for BCG unresponsive disease, followed by maintenance, by the monthly maintenance. And then things that are on the horizon in terms of getting to our clinical practice include adstiladrin, which is intravesical nadofaragene furadenovec, which I think if we go to the next slide, we can talk about the data for that. So, there's so many, as you can see, there's so many options in this space. And so for me, I like to think about things in terms of both the data, but also the logistics. What are the sort of short and long-term outcomes for patients and sort of the real world ease versus barriers? I think this one really does win in terms of ease of logistics. If you can go to the next slide. So the interesting thing about the cohorts that this study was based on was that these were incredibly highly pre-treated patients. They had extensive BCG history. They were all BCG. They really all did meet that BCG unresponsive FDA definition. And they divided the cohorts into these carcinoma in situ and non-carcinoma in situ cohorts, which is also very useful for the clinician as well. You can see the Kaplan-Meier curves here. The patients with high-grade TA or T1 did really well. The carcinoma in situ patients did well as well, but you can see that it wasn't quite as good a response, a recurrence-free survival response as in the others. But overall, their 1 year free from high-grade recurrence for carcinoma in situ was about 24%. And when you think about how pre-treated these patients are, those are pretty promising results. Ultimately, about a quarter of patients did undergo cystectomy. 5 of those were with muscle invasive disease. 1 patient did have nodal disease, and no patients died of bladder cancer over the course of the study. So also a little reassuring.
Yeah, and so I think that I end up showing this table, and I'm hoping our video is not affecting some of the slides, but this is just a summary of everything we've sort of discussed in terms of pembrolizumab, natafaragine, gemdose, as well as some other kind of medications and drugs on the horizon, and a little bit of a summary of doing of looking at this from both 3-month CRs, 12-month CRs, treatment schedule. If you can look, Vicinium is something that sort of also made a splash in terms of having some fairly good 3-month CRs and for papillary disease, 12-month CRs. But the treatment schedule, I put a lot because it is weekly to biweekly treatment. And when you look at the potential doctor visits, assuming a CR, including cystos, it kind of does not hit that sweet spot like Sumeet was talking about in terms of real world ease. Whereas when you look at natafaragine, those visits are a little less because of the 3-month dosing. And so I think that brings up a really important point, not only oncologic outcomes, but practicality. I'm going to move our video just a little bit, hopefully here, down to the bottom, just to sort of show the very right side of this slide, which is N803, which is another intravesical drug, an IL superagonist. And this also showed very promising results in a heavily pretreated patient. But I think what all this sort of tells us is that there's a lot of drugs and a lot of excitement in this space, but with that is going to come some real hard questions about how many of these will we try for our patients in a row? How do we sequence these? What will we use to do that? And I think we've discussed a lot of those different probabilities. And I think, Sumeet, I'm going to turn this back over to you. Is there anything of such as too much bladder preservation for these patients, particularly as we get more and more and more options?
Yeah, I mean, I think it's just important for us to kind of drive home that these are the highest risk non-muscle invasive bladder cancer patients that we're talking about in all these cases here. And so that's always in the back of our mind as well. So in terms of, is there risk to too much bladder preservation? Well, of course, we know that there's the risk of having occult lymph node disease in patients with carcinoma in situ, which is not insignificant, which we'll talk about. And we also know that there's a risk of progression to muscle invasive disease. We know that patients with this secondary muscle invasive disease do not have as good a 5-year cancer specific survival as those who present with muscle invasive disease. And, you know, one has to wonder how much of that is that factor of time. You know, somebody comes into your office with muscle invasive disease, certainly you're going to go to that, go to cystectomy and the potential for that curative effect. So this is a study out of USC several years ago now, and Sima, if you can advance the slide, what we did from our institutional database is we looked at 114 patients who underwent cystectomy for clinical non-muscle invasive bladder cancer. About 60% of them were T1. These were all high-risk patients. Overall, upstaging to muscle invasive disease was about where you would expect. It was about 15%. But when they looked at lymph node metastasis overall for this cohort, it was 8%, which was not insignificant. And in particular, in the carcinoma in situ group, it was 12%. And you can see here that some of these patients had lymph node metastasis, particularly the CIS patients, even in this sort of very high level 3 zone, although there were no skip mets. So that's just something to keep in mind. We recently re-updated this analysis, to more contemporary cases, and again, we're right there at that 12% lymph node metastasis rate in these carcinoma in situ patients. So another number to keep in mind. Of course, we have to balance this with what matters most to patients. This is a recent abstract from Noah Hahn, where we surveyed patients from the Bladder Cancer Advocacy Network, patient survey network. And the endpoint that patients with non-muscle invasive bladder cancer cared about the most was keeping their bladder. It was not complete response. It was not 2-year recurrence-free survival. And in terms of a tolerance for toxicity, when we're talking about things like immunotherapy, et cetera, there's a pretty high tolerance for reversible toxicity, but as you could expect, a pretty low tolerance for any permanent toxicity. So these are all kind of things that we need to weigh and discussion points we need to hit on with patients, probably from the beginning and repeatedly through this journey.
Awesome. And so it looks like that for this patient, after their second carcinoma in situ recurrence that made them in that traditional BCG unresponsive definition, that he ended up opting for a radical cystectomy. And I think this points out the case, the data that you just presented regarding his pathology and the risk of occult invasive disease, right? Our clinical staging does not always match our pathologic staging. And so I think that this is a nice highlight of that. So with our last 10 to 15 minutes, I'm going to move on to the next case. 58-year-old woman with an autoimmune dermatomyositis. She had a workup that included a urine cytology that was positive. And for this reason, she was referred over. Her medications are related to her autoimmune disease. She is a never smoker. She had a cystoscopy and then a TURBT with blue light, which showed a large high-grade TA tumor. Muscle was present and not involved. There was carcinoma in situ kind of colliding with adjacent to the tumor. Repeat TUR was also done in her case, which again showed carcinoma in situ and no residual papillary disease. Upper tract imaging and everything was clean, lymph nodes clean, and for treatment, this is Dr. Kukreja's case, Janet's case, and she had elected to do gemdose, partially in part to her severe dermatomyositis. She had her first 3-month cysto, which was negative for recurrence, and has been on gemdose monthly. And so, Janet, I'm going to turn this over to you. Discuss a little bit about why did you start with gemcitabine docetaxel? Did you consider BCG in this setting? Was there no BCG available?
Yeah, thank you. So this patient, we did have BCG available. However, I thought that this was a good case to kind of pretend that maybe I didn't have BCG available. I had a serious conversation with the patient and her dermatologist about what was going on, and they felt that the BCG could exacerbate her dermatomyositis, and she was already in like physical therapy. She'd lost her hair. I mean, she was just really reeling from the side effects from it. And so we also did talk about cystectomy, and she was not up for it. So we decided to do the gemcitabine and docetaxel. Her first cysto was negative for recurrence, and she's going to start, and she just started her monthly gemcitabine docetaxel. But I think this is a great opportunity to talk about the BCG shortage and how we've managed it, why it's here, and kind of what to do with it. Next slide. So what happened to all our BCGs? So the FDA approves all the medications that we administer in the United States, whether they're from other countries or not. And so basically the FDA shut down one of our BCG producers. And so then that left a sole producer, Merck, and they are the only ones that have been supplying BCG for the last I think 3 years now. And so patients ask this all the time because the patients are very well aware of the BCG shortage. And, the question is, well, why don't we have it? Well, it's really hard to make, actually. And as the batches go through, it takes about 3 months. There's very strict quality control. And if at any point that batch fails the quality control, the whole batch is done. In addition, there's a lot of places that have BCG vaccines, and the dose of the vial of one vial has a ton of vaccines, but it's only one dose for one of the induction or maintenance or whatever. In addition, there's not a great financial incentive for this. And surprisingly, even though Merck is the sole producer, it's still actually relatively very cheap to get. So what to do if you're experiencing a shortage and how to kind of avoid a shortage. I found it really interesting when this all started. I was just like at the very beginning of becoming an attending, and I found out that BCG, they just ship it. There's like no tracking number. You don't know when it's coming. It just kind of shows up at the pharmacy. I was like, Amazon has a much better practice on how they get things to people than Merck does. So I thought that was a little bit strange. But there's no other approved intravesical agents for induction or maintenance in the intermediate or high-risk muscle-invasive bladder cancer. So basically, there's no real substitute for it. So addressing modifiable risk factors, smoking cessation and all that stuff, and also high-quality TURBT using blue light if you have it available to find everything that you can. So in 2019, the EUA put out some guidance, and this is really based on the risk categories that go along with their guidelines. So low risk patients should not be getting BCG at all. The intermediate risk, the preferred is intravesical chemotherapy. They said mitomycin is their preference, but there's not really a lot of data on that versus gemcitabine docetaxel. I personally use gemcitabine docetaxel in these patients up front because it's really well tolerated. And I think I have some of the fears about mitomycin that we talked about a little bit earlier. And then a third dose of BCG as a second line. So the preferred is chemotherapy. And then for high risk, we talked a lot about maintenance today. We talked a lot about the SWOG protocol that goes for 3 years. The guidance was for those high risk patients to do a year of maintenance. And then what I do in my practice, so we usually do half dose for the BCG maintenance. So induction, we try to do full dose, and then for maintenance, we try to do half dose. And I mean, patients still have symptoms. They still have the lower urinary tract symptoms. They still, have low grade fevers. I mean, they're still producing an immune response. So I think it's gonna be really interesting after this BCG shortage is over, what the outcome is if this third and half dose maintenance is actually adequate. And in the future, maybe that's something we're going to move forward to. And then of course, patients with T1 high grade, they're the highest of the highest risk. And then if they have other risk factors associated like CIS or lymphovascular invasion, or it's a large tumor, really push for cystectomy in those patients. All right, and then this is the last slide. And so this is actually based from an interesting meta-analysis that was published in 2017. And so basically it looked at what we do with a BCG naive patient. And the RR is recurrence risk here, and then the 95% confidence interval. Basically, there was no real difference in recurrence and progression when it was compared to BCG for induction. So when we're looking at those, short, intermediate time points, but if you're giving BCG maintenance, it's superior to all these chemotherapies. And I mean, I think for the most part, a lot of people have moved from just single chemotherapies to the doublet chemotherapies that they talk about. So in the graphs here, you see the gemcitabine with mitomycin with pretty good, on par with what everything else we talked about today for recurrence-free survival, 44% at 2 years. And then the gemcitabine docetaxel has a better recurrence-free survival for patients that do not have CIS. When you look at the CIS anything, so CIS alone, CIS plus TA, CIS plus T1, all those numbers of recurrence-free survival are much lower. But if you have just TA, just T1, I mean, the 60% recurrence-free survival at 2 years is great.
Yeah, we've been using gemcitabine and docetaxel as well as a BCG replacement. I mean, it is unpredictable. We count vials every 2 weeks, and then try to plan ahead because you never know what's going to show up in terms of BCG. So sometimes we're like BCG rich, and sometimes we're like calling everybody there's none, switching things around, splitting doses. And so we've tried a few different systematic ways to not have so many ebbs and flows, but yes, again, the shipping process, it's pretty difficult to predict. Dr. Murray, what has been your experience in terms of the BCG shortage? Have you felt it at all over there, or not really as much?
Yeah, so we, same situation that everybody, that Janet's talked about, and you as well, Sima, but we've really been trying to try to coordinate patients. So we have gotten rid of doing, maintenance, especially, except for those really high risk patients that absolutely need it. Otherwise, we're giving no maintenance. And trying to, put 2 appointments, 2 patients that need it right on top of each other so that we can split doses. In reality, it seems like it should be very easy to do scheduling, right? We all know that the reality of that scheduling is somehow turns impossible. And so it is, but there have been patients, that we want to start on induction, and we say we're going to start, in 2 weeks, and we end up starting in 4 weeks because, the week ahead of time we're calling and we're saying, oh, we don't have it, but kind of be on call. And as soon as it gets here, we'll get you in and get you started.
How about you, Sarah?
Yeah, I mean, I think we've done, it's amazing how we've all become sort of masters at these logistical sort of juggling acts. We've stacked our appointments to be able to split vials and make sure we don't waste a penny. We were really judicious with maintenance early on when we were really feeling the shortage. Now we are in a little bit of a better situation, but I will say that we're one of the few centers right now in Washington State that has it. So we're seeing patients get referred in so they can get BCG here, and we're kind of carrying that. We really relied on clinical trials. So for example, when SWOG 1602 was accruing, we just were putting everyone we possibly could on that because that was one way. It's a great trial, and we really are excited about those. We think it's really important to study the different viabilities of these different strains of BCG, and also I think the primed arm that's going to be a really interesting hypothesis to test. But beside all of that, that was one way we could get patients BCG. There are other sort of high risk trials that we have ongoing right now in the BCG unresponsive state for certain those patients, instead of just going with a second induction course if we don't have the BCG, thinking about one of the trials that are available for those patients, I think can be really helpful. But it has been tricky, and I think relying more and more on the gem dose as well is important. But it's something that we just have to be very upfront with patients about, and then like you've all talked about, I mean, it's just understanding and sort of massaging the logistics to try to maximize the utility of the BCG we've got and minimize any waste.
Yeah. How about you, Sumeet? Have you guys experienced shortage?
Yeah, I mean, similar to what everybody has talked about, the logistics seem easy, and I don't think that it has not worked out very well in our practice. And so we're not doing a lot of split doses actually. We have no maintenance. We've had no BCG for maintenance for many months now. We were heavily enrolling into 1602, and we all sort of breathed a sigh of relief and didn't at least have to worry about could we get induction for our patients or not. Now we're back on that train where we have these lists and these waiting lists, and you know, we're just used to kind of immediately after you get the pathology report, putting them on the waiting list. And usually you can, you know, there's something available within a few weeks and you feel okay, but it's always teetering on this edge. I have used gemdosi for BCG naive patients in certain cases. But yeah, and in terms of clinical trials, you know, like we've talked about, to get them on the trial, you also have to have had them get BCG and get, you know, one induction plus two of another. And so it's a whole, you know, balancing that as well. So yeah, similar to everybody else. What's interesting is on our campus, that was a situation at our cancer center, and across the street at our county hospital, they have had zero shortage the entire time. And so the supply chain thing is the most interesting aspect of this whole thing. And there's no transparency on it. And so, you know, and it doesn't seem like it's going to stabilize anytime within the next year or so. So yeah, at least space for a lot of trials and accrual to trials, I think, because of it.
Awesome. Well, thank you guys for joining me today for this panel discussion and this case discussion with real world cases. I particularly like that they were not all like in these perfect set, you know, definitions, because I think it really does reflect how complex practice can be today. For those of you out there watching this, please use the QR code and take a survey and fill out the evaluation. And I look hopefully forward to doing this again when we have even more options and we're sort of discussing multiple options in all the different spaces. Thanks again, and I hope everyone has a great evening, afternoon, wherever you are.